Good morning. Welcome to Medical Grand Rounds. It's really my pleasure and honor to introduce this year's 25th annual Roger E. Pecoraro Memorial Lecturer. The Pecoraro Lecture, as I said, was established 25 years ago in honor of one of the founding members of the Division of General Internal Medicine, and is the single major lectureship in our division every year. This year's speaker is truly an honor to have Dr. Rosenthal from the University of Iowa. Dr. Rosenthal is a very distinguished internist in sort of every aspect of academic medicine. He did his undergraduate work at Hopkins, medical school at Penn, internship and residency at Case Western, where he joined the faculty and rose to the rank of tenured associate professor, at which point he moved to Iowa to be head of the Division of General Internal Medicine, and went on to establish one of the finest divisions in the country at Iowa. He's also directed the CTSA for several years at Iowa, and is currently serving as the interim chair of the Department of Medicine. He's exceedingly well published in a variety of areas. He's worked in the areas of quality of care, clinical outcomes, case mix adjustment, patient preferences, all areas which are very current in today's research. He started working in those areas 2 decades ago and did much of the foundational research on which we all depend today. He began one of the earliest quality of care consortia of hospitals in Cleveland, and now that model of both studying and assuring quality of care is very common throughout the country. Their work was one of the first. He's trained innumerable mentees, 30 or so to be exact, almost all of whom have gone on to pursue in their own right strong academic careers. He has served nationally on numerous study sections, both at the Agency for Healthcare Quality and Research and within the VA, and has received in several important national offices. He served as president of the Association of Chiefs of Leaders in General Internal Medicine, which is our division chiefs organization, and also as president of the Society of General Internal Medicine, which is our major academic society. So it's truly a pleasure to have Dr. Rosenthal visit us today, and he's going to talk about integrating learning into clinical practice and how we will lead the way. So please welcome Dr. Rosenthal.
Thanks. So good morning. It's an absolute pleasure and privilege to be here. Had a great time last night at the Pecoraro lecture, having the chance to meet with a lot of the faculty in general internal medicine. This is really a very special place. While the department is not one of the oldest departments in the country, it's had over the last 70 years has really had just a remarkable impact on American medicine, and it's been blessed by great leadership. And I think one of the most amazing and telling things about the department is that in its 70 years it's been led by 5 chairs, which I think says a lot about the institution. It's also this is a very special place for general internal medicine, in that the University of Washington really helped birth the field. It's been the home of a number of leaders in general internal medicine: Steve Finn, David Dale, Eric Larson, Tom Inouye, and many others. And it's been a place that I've looked to, as a model for, developing general internal medicine. And certainly Steve has been, just an exceptional role model for me. So what I want, since this is grand rounds, I wanted to start off with a bit of a case history. So our patient today is the U.S. healthcare system, and rather than going into sort of the history and physical, let me just present sort of a very brief biopsy of what we see. So the first thing you're struck with is we spend a lot of money. So total expenditures in 2014 of about $3.1 trillion, and relative to the economy, we spend almost 1 in 5 dollars on health care. Relative to other nations, our per capita expenses are 50% higher than the next most expensive nation, and anywhere from 2 to 2.5 times higher than the median for other industrialized nations. Unfortunately, in many aspects, we don't do that well. This is some data from the study that was done by the Commonwealth Fund, which compared a number of measures of healthcare access, safety, efficiency, care coordination, and equity in the U.S. and 6 other nations, and found that on all of these metrics that we rank last or next to last. And the other thing, that you're really struck with regard to U.S. healthcare delivery is that there's tremendous variation across the U.S. in costs, and unfortunately, higher costs do not yield higher quality. So this is data from a paper that was published 11 years ago in Health Affairs, that in these data really haven't changed. So this shows state rankings for 24 different quality measures in Medicare patients on the y-axis, and it shows spending on the x-axis. So what you'd really like to see, if you're getting value, is that the more you spend, the higher the quality. And unfortunately, what you see at a state level is that expenditures, higher expenditures per Medicare beneficiary are actually associated with lower quality rankings at a state level. So I think when you look at this biopsy, the inescapable diagnosis is that we get really, very little bang for the buck. And in fact, recent estimates are, that 30% of Medicare spending could be avoided, without worsening patient outcomes. That was an analysis from Elliot Fisher at the Dartmouth Institute. And Don Berwick, while he was administrator at CMS, wrote an op-ed piece in JAMA that stated that roughly a third of healthcare, expenditures are wasteful. So why is this? And, I think the underlying factors on the value equation, in U.S. healthcare are very complex. But I think an important aspect of it is that in many areas we have lack high-quality evidence on what actually works. And it's really striking that, it's stated, that less than 20% of the interventions that we commonly use in clinical practice are based on evidence, from randomized, clinical trials. So think about that for a second. We hold up randomized clinical trials as the holy grail of evidence, and yet 1 in 5 of the, things that we do are actually based on that evidence. And then when you, dig a little further, you recognize that many large randomized trials study homogeneous populations, which limit the generalizability, to a large percent of patients in practice, including those with multiple comorbidities. And when you look at sort of the cost of traditional multi-site clinical trials, they're incredibly expensive and, run, typically anywhere from $50 million to $250, million. So the question remains, so how can we really build an evidence base to try to drive high-value care? And I, respond to that question, by noting that I think we're at an amazing place in time in healthcare delivery. that we really have, an unprecedented opportunity to do something, very special and create learning health systems that really integrate research on the effectiveness of care into routine practice, and to create an environment in which research on what actually works in care is seamlessly embedded, in our delivery process. So as a result of a number of advances in healthcare technologies, we really have the ability to mobilize vast amounts of data from EMRs, from billing systems and clinical registries, which can really provide unprecedented, granularity on what happens to patients as they, move through our healthcare systems. We also have, the ability to engage patients in research in very new ways through mobile and web-based technologies, and to collect data, on their health and well-being. And we lastly have the ability to utilize the EMR to identify patients who may be eligible for particular studies, and to recruit these patients into studies, and then to communicate with their clinicians. So the remainder of my remarks today will really focus on this opportunity that I believe is before us, and the things that must be done to make it a reality. So I want to, I'll touch on sort of, three main areas. So first I'll present, just working definitions for you of the learning health systems and practice-based pragmatic trials. I'll spend some time contrasting the differences between pragmatic trials and, traditional clinical trials. And then I'll review what I feel are some of the important methodological and cultural issues that must be addressed if we're really going to advance agendas in practice-based research and enable, high-value learning healthcare systems. So, many of you are probably, familiar with the term learning health system. So it first emerged in a Institute of Medicine report in 2007. And that Institute of Medicine report defined the learning health system as a delivery system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge, captured as an integral byproduct of the delivery experience. What a place. I'm sure, a place that we would all like to practice in. Since that initial conceptualization of the learning health system, there's been a number of frameworks that have been put forth to sort of talk about some of the theoretical underpinnings. And probably, I think, the best one was a model that was put forth by Sarah Green and Eric Larson from Group Health that was published in the Annals of Internal Medicine in 2012. And they describe sort of 6 distinct phases of learning in healthcare. There was the first phase. It starts with, scanning and surveillance, which involves sort of proactive identification and characterization of key problems. The next phase is design, which really involves convening a large group of stakeholders to develop interventions and evaluation systems that actually are tailored to particular clinical settings. And then from design, we move to implementation, which involves careful piloting. And then what's critical is that there's evaluation, that can provide timely feedback on effectiveness. And then often with most organizational interventions, there's a need to make adjustments and fine-tuning. And then finally is the process of dissemination and spreading the knowledge that's learned both to internal and external audiences. Now, I think, if you step back, and think about it, that, learning is something that's intrinsic, to academic medicine. So what's different here, with the concept of the learning health system. And I think there's sort of three, main distinguishing features. And the first is that that in the learning health system, there's this very tight integration between research and practice, so that research findings directly inform practice, and a lot of the key issues that are faced by practitioners become the focus of future research projects. Second feature, I think, is that research is conducted in routine practice settings with very modest research infrastructure. So there's this real embedding of research into practice. And the third feature is that the learning health system capitalizes on a number of resources, such as the EMR, that are an integral part of the infrastructure. So having sort of presented a bit of a framework for the learning health system, I'll just talk for a bit about pragmatic clinical trials, which are have really recently come into vogue. But like most things in medicine, when you actually look and trace back the history, you find that the idea was actually put forth nearly 50 years ago in an article by Daniel Schwartz and Joseph Lelouch. And in that article, they distinguished between trials that were explanatory in orientation and trials that were pragmatic. Explanatory trials were really aimed at mechanistic understanding in their model. And the goal of these trials was to really discover if a difference exists between treatments that are specified by strict definitions, while pragmatic trials were really aimed at clinical decision-making rather than purely mechanistic understanding. And the goal of pragmatic trials was to discover which treatments would be preferred as those treatments would actually be administered in clinical practice. Since that initial, sort of articulation of pragmatic trials, there's been a large amount of literature, that have sort of further tried to characterize differences between pragmatic and explanatory trials. And I recognize that I'm going to go over some of these features, but recognize that these tend to be broad generalizations, and oftentimes different studies have features that are sort of somewhere in the middle between purely pragmatic or purely explanatory. One of the big differences in a pragmatic trial and explanatory trial is that explanatory trials often enroll very homogeneous patients with few comorbid conditions to reduce response variation. And they do that for a very specific reason, because they want to try to maximize efficiency and limit sample size, because these trials are very expensive. In contrast, pragmatic trials have fewer patient selection criteria, and they seek to enroll more heterogeneous populations, and they may have higher external validity but lower internal validity. They may require larger sample sizes because of this heterogeneity, and they oftentimes require longer follow-up to track outcomes, because there's a desire to actually track outcomes that reflect real-life concerns of patients rather than surrogate endpoints. There's also, differences in the treatment and control groups. So very often explanatory trials will compare new treatments to placebo treatments. Pragmatic trials typically compare two or more standard of care treatments, often for which there's a clinical equipoise. So we might do something one way at Iowa, you may do something another way at the University of Washington, but there's general acceptance that both of those approaches are within the realm of sound clinical practice, but we really don't have the evidence to say which one is really better. In pragmatic trials, important distinction is that patients and clinicians are typically not blinded to treatment assignment. However, what's really critical is that the allocation to the study groups, has to be random, and just as importantly, the assessment of those outcomes, really does need to be blinded. There's also, differences in the interventions that are tested in pragmatic and explanatory trials. So explanatory interventions are often delivered by very specialized practitioners in tightly controlled settings in an effort, to maximize intervention fidelity. So to make sure that every individual who gets an intervention, gets the same dose of that intervention. In contrast, pragmatic interventions are delivered in routine practice settings. They have, very modest infrastructures to support the intervention, and as a result, they have to incorporate flexibility to account, for a lot of the individual needs of patients as well as the capabilities of different delivery settings. To try to make this a little bit more, concrete, I want to present an example of a pragmatic trial that my colleagues and I are developing, and actually have a proposal into PCORI right now. So we want to ask the question of whether or not taking once daily blood pressure medications is more effective in decreasing the risk of adverse cardiovascular events in people who are randomized to take their medications in the morning or at night. At first blush, at least, a very simple question. So what's the rationale for this trial? So as many of you probably know, blood pressure exhibits tremendous circadian variability. It's typically lower during sleep, this phenomenon known as nighttime dipping. And then it increases on waking up, and this actually may be part of the reason for some of the excess risk of heart attacks during the early morning hours. Epidemiologically, sleep blood pressure is actually a stronger predictor of cardiovascular risk than daytime blood pressure. And in particular, the lack of nighttime dipping is associated with significant excess cardiovascular risk. And this is a particularly common phenomenon in patients with both diabetes and chronic kidney disease. And sort of a further rationale for the study is that many of the blood pressure medications that are taken once daily, don't sustain plasma levels for a full 24 hours. And when those medications are taken in the morning, it may not promote nighttime dipping as well or protect against this morning surge in blood pressure. And the last rationale was some 3 trials in Spain conducted by Hermida and his colleagues, using a traditional explanatory design that found that patients who took 1 or more blood pressure medications at night had a 65% reduction in cardiovascular events. Now, that's absolutely astonishing. I don't think anybody really believes that data. And to sort of put that 65% reduction in historical context, that's the same reduction that was observed in the very early Veterans Cooperative Study on treatment of hypertension, where patients who had diastolic blood pressures of 90 to 110 were given active treatment and compared against placebo. But so even though that estimate is probably very high, I think it's suggestive that there may be something here. So a brief overview of our trial design. So we're going to enroll patients with hypertension and diabetes, age 50 to 85 years. Other entry criteria, relatively minimal, 2 or more ambulatory visits in the past 12 months to primary care, prescriptions for once daily ACE or ARB. We're going to obtain informed consent using either an online interactive consent module or a mailed consent letter, and hope to follow patients for 36 to 42 months with follow-up contacts every 6 months. So a very efficient trial design. We're going to obtain occurrence of cardiovascular events from existing data from the EMR, from online surveys of patients, as well as other data that may be available, such as Medicare claims and death certificates. We're going to look at a composite endpoint of death, hospitalizations for AMI, ischemic heart disease, heart failure, and stroke, as well as coronary cerebral or peripheral revascularization procedures. We're are targeting an enrollment of about 12,000 patients at 8 sites in order to try to detect what we feel is a more reliable estimate of the effect size of perhaps 10 to 15% for the composite endpoint. And the key thing about this trial is we would hope to complete it for about $10 million or $800 a patient, which is about 10 to 15% of the cost of traditional multi-site hypertension trials. So some of you are probably familiar with the SPRINT study, the findings which were presented at the American Heart Association last week that actually found that in patients with hypertension, a target systolic blood pressure of 120 rather than 140 was associated with about a 25% decrease in cardiovascular risk. So SPRINT enrolled 9,300 patients. I don't know what the total cost of the study was, but when the study was initiated, they had planned to spend about $114 million. So why is our nighttime dosing trial a good topic for a learning health system pragmatic trial? So as we all know, hypertension is a very common problem. It's a major risk factor. We can identify the eligible patients through the electronic medical record. The key endpoints can be captured through the EMR and other data sources. And importantly, this is an intervention that could be implemented in practice without the need for any kind of sophisticated infrastructure. And we think that the intervention would have a high potential for sustainability. Actually, if the pragmatic trial, confirmed prior clinical trials. Okay, so the last, general area, that I wanted to get into, this morning is to really talk about some of the key issues that we'll have to address if we're going to, really build pragmatic trials into our delivery systems and create this idyllic learning health system. So I'll talk about 4 areas. The first is the importance of improving our efficiency of subject recruitment. The second area is the importance of developing reliable clinical phenotypes from EMR data and really to try to improve the quality of information that can be captured in the EMR. The third area, is more effective strategies that have to evolve for engaging healthcare systems and physicians in practice-based trials. And then I'll touch on, the importance of trying to decrease regulatory barriers for conducting, lower risk pragmatic trials. Okay, so the first area, so improving the efficiency of subject recruitment. So unfortunately, inadequate recruitment is really one of the biggest challenges that we face in the U.S. clinical research enterprise. It's a huge concern of NIH, and it's one of the main reasons why so much of the clinical trials industry is moving overseas. When you look at the data on trials, so more than 80% of trials are delayed at least 1 month because of unfulfilled enrollment. There was a study almost 10 years ago of 114 multi-center trials in the UK. They found that only 31% achieved their planned target enrollment and 53% had to be extended. In another analysis of NIH-funded trials, only roughly a third met their planned enrollment and a quarter did not reach actually 50% of their planned enrollment. So this is problematic in that studies are often underpowered and don't have the ability to really test the hypotheses that they were designed to test. And from a patient standpoint, when patients volunteer for studies and the actual study really can't accomplish its goals, I think that raises actually a lot of ethical issues, with regard to, clinical research. So in recent years, there's been a lot of efforts to focus on better approaches to enhancing recruitment, and there's a lot of interest right now in trying to utilize the EMR to enhancing recruitment. And probably the first study that looked at this and sort of highlighted the potential was a relatively small study. Was done by Peter Embi while he was at the Cleveland Clinic and published 10 years ago. And what Embi did was he developed a electronic medical record alert, for a diabetes trial that identified patients on the basis of diagnosis, age, and glycosylated hemoglobin levels. He then targeted that alert. And I realized that when I mention the term alert, there's probably a lot of dyspepsia in the audience. So he, targeted the alert to 10 endocrinologists and 104 general internists at the point of care when, the physicians were seeing the patients. The alert asked physicians to consider several other exclusion criteria that they couldn't obtain, from the EMR, and then to send referrals to a coordinator if the patient wanted to participate. So what were the results of this study? So he compared enrollment in the 12 months before and the 4 months after the alert was implemented. And in the 12-month control period, he found that there were only 5 physicians who referred 68 patients to the coordinator, and they saw an enrollment rate of about 2.9 per month. In the 4-month intervention period, in contrast, he had 42 physicians referred a much larger number of patients and obtained an enrollment rate, that was double. This is an area that we've actually put a lot of resources into through our CTSA program. And this was sort of our initial experience in utilizing the EMR as a basis for recruitment. So this was in support of an NIH-funded randomized trial of an intervention to increase visual processing speed in older adults. So probably a lot of you have heard the advertisements for Lumosity, and it's sort of video games that make you smarter and happier. So this was, we used an electronic medical record-based algorithm to identify patients in general medicine and family medicine clinics who were 50 years and older, had 2 or more clinic visits in the past 12 months, and didn't have a diagnosis of dementia. We sent a single mailing out to 5,700 patients, and almost 1 in 6, 996, expressed interest in participating. And then from that, the investigators were able to enroll 680 patients over a 6-month period. So a very, efficient enrollment process. Another, I think, promising, development on the horizon is online subject enrollment. And I think there's, in addition to enrolling patients, there's increasing interest in trying to utilize online platforms to promote both awareness of trials and to obtain informed consent. And there's some very promising early data that actually multimedia and interactive e-consent formats may improve subject comprehension of studies, which, I'm sure anyone who's enrolled patients into a clinical study sort of recognize the current cumbersome nature and length of our, informed consent documents, and, often wonder, what patients are, really understanding from that process. This was a study that was published electronically by Chris Simon, who's a colleague at the University of Iowa. And what Chris did was he randomized 200 patients who were being recruited for our biobank and collection of biological specimens to a traditional consent process with a coordinator, or to 3 different electronic consent arms. One was an arm that featured a multimedia presentation, the other arm featured with electronic consent was very interactive, where patients were asked about, their understanding of a study. And then he looked at sort of an arm that had both multimedia and interactivity. And what he found was that, patients in both the multimedia and the interactive arms had higher knowledge scores of the purpose of the biobank and how their samples would be used. But he found that patients in those two arms actually had similar scores as patients who got both the multimedia and interactivity, so he didn't observe an additive effect. And I think that this is really important data because, oftentimes IRBs have a hard time, thinking about online consent mechanisms and, data that shows that it actually can improve, subject knowledge, I think will be incredibly important in the future. Okay. So a second big issue is developing reliable clinical phenotypes from EMR data and improving the quality of information in the EMR. So as many of you are aware, some of our current challenges are that most of the information in electronic records is contained in clinical notes in free text formats, can be very difficult to extract, given where we are with regard to natural language processing methods. There's also tremendous variability across different EMRs in capturing diagnostic and phenotypic information. This is a particular problem, for diagnoses, and even within individual institutions, the same EMR, there's a lot of variability from clinic to clinic. And then there's a limited standardization of phenotypic definitions for most clinical conditions. And I'll present some results from a study that a colleague of mine at the University of Iowa did, Thad Abrams, on sort of the impact of unreliable phenotypes. So the question that Thad wanted to ask is, what is the impact of comorbid depression on in-hospital mortality? This was a study that he did within the VA. He looked at 21,000 consecutive admissions to VA hospitals, and he used two approaches for defining comorbid depression. One was he just extracted diagnoses that were recorded during the incident admission, the AMI admission. And in the second approach, he used diagnoses that were recorded during prior clinic visits. And this is what he found. So when he just relied on inpatient diagnoses, he found that only 10% of patients carried a diagnosis of depression. However, when he looked at outpatient diagnoses, he found that almost a quarter of patients actually had a diagnosis of depression. So that in itself, isn't as troubling. But what he found was that when he looked at the adjusted odds of death for patients with depression relative to patients without depression, when he relied on inpatient diagnoses, he found that patients with a depression based on an inpatient diagnosis had an odds ratio of death of 0.89, or about an 11% lower risk of death than patients without depression, which probably doesn't make, I think, much clinical sense. However, when he looked at outpatient diagnoses as a means for identifying depression, he found that patients actually had about a 20% different risk. So what this is saying is that these two phenotypic definitions of depression, actually are probably identifying, very different populations with regard to, their underlying risk. So what do we need at this point? Well, I think, what's important is that we really develop a national standardized library of computable definitions, for most key clinical conditions, that we try to validate these definitions across different EMR systems and different institutions, and that we standardize approaches used by clinicians in entering clinical data elements into the EMR, trying to increase the use of structured fields and flow sheets, and really try to synthesize, best practices for EMR data entry. And I think that, as we talk about pragmatic trials and the mobilization of big data, it's incredibly important, that actually the data be reliable if we're really going to generate, valuable knowledge. Another really important area is that we need more effective strategies for engaging systems and physicians in practice-based trials. In terms of the barriers, I don't really need, to go into these in a lot of detail. It's things that, you all live with, every day. So our practices are busy, whether in the community or academic environments. Clinicians typically have economic incentives to maximize visits, but few incentives to participate in research. So no matter what you're studying, when you come into a clinic, the research may be perceived as burdensome, distracting, or disruptive. Oftentimes, clinicians actually have little interest in the topics proposed. And the timelines of clinical leaders, for gathering data and decision-making are typically much shorter than research timelines. So here are just, my thoughts on some of the strategies that need to be implemented for overcoming these barriers. First, recognize that engagement is not a one-size-fits-all proposition. We'll need to employ very different strategies and different practices. So you really have to know the customer. You have to be cognizant of past history and experiences, both positive and negative, that the practice has had with research. Third, I think it's very important to recognize that there are formal leaders, so clinic directors, as well as individuals who can't play major informal roles as opinion leaders or often as naysayers and can doom a project from the start. As we try to really integrate research into practice, we have to come up with study designs and interventions that can be easily embedded into practice and not impede workflows. And then a couple of other things. I think it's very important, but it's often overlooked, is that we have to return the project results to the settings in which the study was done. And oftentimes, particularly with health system leaders, if you can benchmark the data to other institutions, it's very helpful in getting their support in terms of being able to put the results in your practice into a larger national or regional market context. And I think one of the sort of most challenging areas is that we have to figure out how we can integrate incentives for research participation into our current faculty award systems. So I propose that we think about clinician participation in pragmatic trials as a factor in promotion. And one of the areas that, as interim chair, that we're beginning to experiment with is trying to better align the economic incentives. So we're introducing a system of actually providing RVUs for subject recruitment into trials. So that, and we have a very heavily based RVU incentivized program for clinicians. So recognizing in an economic, sense the time that it takes for subject recruitment. And so the last area that I'll talk about is the importance of decreasing regulatory barriers for conducting low-risk pragmatic trials. So I think it's, in this context, it's very important to recognize that pragmatic trials typically involve interventions that are low risk in nature and that involve the comparison of interventions that are commonly used in practice and for which there is often clinical equipoise. It's also important to recognize that randomization is a critical part of pragmatic trials and that obtaining informed consent for conducting randomized research can be a major barrier. So recently, there's been some very important national dialogue around our current framework for thinking about what constitutes research and about this research practice continuum and how we can decrease regulatory hurdles for conducting pragmatic trials. And many of these issues were captured really nicely in a report from the Hastings Center that came out almost 2 years ago. And the report includes 2 articles by Nancy Cass and Ruth Faden from Johns Hopkins that raise really important questions about our framework for managing practice-based research. The first article reviewed our framework, for distinguishing research from practice, and it reviewed sort of the 4 features that we commonly use to distinguish research from practice, so that research involves a systematic investigation to produce generalizable knowledge, that research involves less clinical benefit and greater risk than clinical practice, that research introduces burdens or risks that are otherwise not part of patients' clinical management, and that research involves the use of protocols, a randomization that dictate which treatments patients receive. And what Cass and Faden did is they systematically identified problems which each of those 4 distinguishing features, and they concluded that those features from distinguishing research from practice were out of date. So as an example, they cited many treatments and tests that were widely used in practice, that were later shown really to be, harmful. And these examples included things like gastric freezing for peptic ulcer disease. We're sort of going through some of the history of medicine here. Things like extracranial to intracranial bypass surgery to reduce the risk of ischemic stroke. Many of you probably remember using antiarrhythmic drugs in patients with frequent PVCs. We thought that would decrease the risk of sudden death, would actually show to increase the risk of death. And even, bone marrow transplantation for, metastatic tumors. So that Cass and Faden make this argument that in many cases research really doesn't expose patients to greater risk than they would encounter in practice. The second article by Cass and Faden, builds on this first article and then presents a new ethical framework, for governing research in a learning healthcare system, and really rejects the fundamental assumption that research and practice are, different beasts. So they identified, 3 key issues. One was, from an ethical framework, they felt that healthcare systems really have a moral priority on learning, and that healthcare professionals and their institutions have a novel obligation, to promote learning. And they extended that obligation to patients, and they justified it by the principle of the common good, that members of society have a common interest in ensuring an affordable, high-quality healthcare system. And then they, the third piece of their framework was that there's an obligation to also address unjust inequalities in the evidence base, for clinical decision-making and in healthcare outcomes. So this has been, I think, a very important piece. There's a lot of discussion nationally about, where we might go with new research regulatory frameworks for those lower risk trials. I think everybody is anxiously awaiting what will actually appear in the revision of the Common Rule, which governs research. And I think there's a lot of hope that some of the restrictions on practice-based research will be eliminated, and it'll be a lot easier, to conduct some of these important trials. So I'll just, wrap up by emphasizing several take-home points that I hope to make in this talk. I think looking forward, pragmatic trials really hold enormous potential for decreasing the cost of answering questions about the effectiveness of interventions that are commonly used in practice. However, the success of these efforts to promote pragmatic trials are going to depend on our ability to come up with innovative strategies to improve subject recruitment, to standardize the clinical phenotypes that can be obtained, from EMR data and other types of data that are readily available. Importantly, we have to decrease a lot of the regulatory hurdles to conducting research that evaluates standard of care treatments. And we have to figure out better ways to engage health systems and clinicians and really incentivize, their participation in pragmatic trials. And then I think that, pragmatic trials can be a central feature of, true learning health systems and this vision, this wonderful vision that was articulated by the Institute of Medicine. And I strongly feel that academic medical centers are uniquely positioned to take this mission on. And I really believe that we have a societal obligation to drive the creation of these systems that can generate the evidence that's really needed to practice high-value care. And I thank you very much for the invitation. It's really been a pleasure visiting, and I guess with some remaining time, I'm happy to take questions.
Interested in this, you feel free to contact those faculty, or if you don't know who to contact, I can help.
Well, thanks for the comment. And for the tachycardia, I can give you a prescription of Maxillatine, if you'd like. But I think you hit on just a number of points about the EMR friend or foe, and that apart from alerts, we really need better EMR systems. And last night we actually had some interesting conversations about some of the challenges with the EMR, with templates, with cutting and pasting, and how it's really decreasing the value of the EMR as communicating information about the patient. And I think the emergence of much better technologies, natural language processing, actually technologies that can go in the room with the doc and voice record and put into notes a lot of aspects of that conversation and make in getting that information in the EMR are going to be incredibly important.
How do you avoid the process? In a traditional research, you're looking for sort of cause and effect. This causes that. As you no longer control those circumstances, how do you avoid getting something that is associated but may have absolutely nothing to do with cause and effect? And it seems to me that we're seeing this a great deal in a lot of studies on food, if you this or that.
Right.
The tendency is to make that a cause and effect when it may not be cause and effect at all. It may be some sort of association that's been picked up. And you end up with kind of garbage in, garbage out.
Well, so I think that's it's a very poignant observation in terms of a lot of the limitations of observational research that, just basically take the data that you have at one point in time and try to make these associations. I think, pragmatic trials are different. So pragmatic trials are actually sort of similar to traditional trials in that they're randomizing patients and then following them prospectively to try to get at some of the, cause and effect associations that are really critical. I mean, it is important to recognize that pragmatic trials are messier, but they reflect practice, and practice, can be, very messy, and there's often, perhaps more caveats that you have to be aware of when you're interpreting the results of a pragmatic trial. But I do think, that they are a very strong vehicle for really teasing out some of the cause and effect relationships that, you mentioned.
Thank you, Dr. Rosenthal.
Great. Thank you.